ADHD is often explained in one sentence. You don't have enough dopamine. So the solution sounds simple. Increase dopamine, take a stimulant, improve focus, and for many people, stimulants can be life-changing. But here's the clinical problem. If ADHD were only a dopamine deficiency, treatment would be straightforward. Give the medication, increase the dose, restore attention, problem solved. But that is not what we see in real life. We see people who focus better, but sleep worse. People who become more productive, but also more anxious. People who can start tasks, but crash later in the day. People who say the medication works, but I feel wired. This is where ADHD treatment becomes more interesting and relevant. Because the aim is not simply to stimulate the brain. The aim is to regulate the system so the person can think, sleep, feel, plan, act, recover, and function. So in this video, I want to explain why ADHD treatment is not just about more dopamine. It's about signal clarity and reducing background noise. It's about sleep. It's about emotional regulation. And it's about knowing when to stimulate and when to calm the system down without the medication. I'm Dr. Sanil Rege, consultant psychiatrist and educator. As someone who's developed over 30 hours of educational material on the Academy by Psychscene for ADHD-specific training, now used by clinicians, governments, institutions, I've realized one important thing, is that ADHD requires a broader lens. So let's start off with what ADHD isn't. The common explanation of ADHD is attractive because it's simple. ADHD equals low dopamine. Stimulants increase dopamine. Therefore, stimulants treat ADHD. Now, there is a small piece of truth in this, but applying this formula generically can be a recipe for disaster. Dopamine is involved in a range of functions, in motivation, salience, reward prediction, the ability to learn, effort allocation, and the appropriate selection of action. Noradrenaline is involved in alertness, vigilance, attention and cognition under stress. Both these neurotransmitters play an important role in the frontostriatal systems. And what stimulant medications do is they can improve attention, reduce impulsivity, and improve executive functioning. But what's important here is to recognize that they don't do this directly by targeting attention. What they do is that they increase arousal and salience. They increase the brain's ability to tag what's important and therefore help the individual stay with that task longer. That's what stimulants do. But the mistake that often occurs when thinking about stimulants is that more stimulation always means better regulation. That is not how the prefrontal cortex works. The prefrontal cortex works on an optimal Goldilocks curve. Too little, and you have the symptoms of inattention, impulsivity, the ADHD construct. Too much, and you have cognitive rigidity, inflexibility, hyperarousal, and stimulus-bound responses where the individual gets distracted by multiple stimuli. So stimulants work best within a range, and the optimal level differs from person to person. So the clinical question in treating ADHD is not, how do we push dopamine higher? The better question is, what state is this nervous system in, and what does it need to function? So if treatment of ADHD isn't just about stimulation, what is the main aim? You see, ADHD is a regulation issue across multiple systems. Regulation of attention, effort, motivation, emotion, sleep-wake rhythm, action. And this is why ADHD affects so many areas of life. And this is why treatment has to go beyond just increased dopamine, because attention, for example, depends on state. And the state that matters most is the underlying state of arousal. Because as I mentioned before, what stimulants do is they enhance this arousal state and thereby increase attention. So if the person is sleep deprived, the arousal is already high. The stimulant may temporarily increase alertness, but it may also worsen the sleep cycle. Similarly, if the person is anxious or hyper-aroused, the stimulant may improve task initiation, but also increase internal tension. If the person is emotional dysregulation, the stimulant may suddenly sharpen cognition with the patient saying, my internal chatter has stopped, but may exacerbate anger outbursts. Or if the person is exhausted, overwhelmed, or running on chronic stress, heightened arousal more stimulation will push them to the opposite pole of the Goldilocks curve. And this may create short-term performance, but long-term destabilization, where the crash and burn cycles become more frequent. Now, for each of this concept, if you want to go deeper, check out the ADHD playlist here, because each of these concepts of performance debt, interoceptive blindness and burnout, masking, or optimal treatment, I've covered all of these in individual videos, which you can find in the playlist here. So what I'm trying to highlight here is that ADHD treatment needs a sequence. And the first step of the sequence is to understand the state within which the person is operating. Then regulate the system. And the third step is stimulate if needed. And I say this because certain regulation strategies, such as improving sleep itself, acts as a stimulant. More detail again in this video here, where you can understand sleep cycles and how to maximize sleep cycles to improve your cognition. So let's think about using stimulants appropriately. We know that stimulants increase dopaminergic and noradrenergic signaling. When prescribed appropriately, they optimize arousal and therefore can improve focus, reduce impulsivity, and help the person engage with the task longer. Key word I want to highlight here is arousal. Arousal creates noise. Stimulants increase the signal and reduce the background noise. But if the signal is increased too much, it gets converted into noise, simply because the volume's too loud. And when the volume's too loud, that's exactly when patients say, I can focus, but I feel tense. I get things done, but I crash. My sleep's all over the place. In some cases, the patient thinks they're going okay, but the family members are concerned because the individual spends excessive time cleaning or is really irritable and snappy with the kids. So at this point, you might ask, are there any medication strategies to help improve control and to regulate the system? Yes, there are. This is where medications, specifically alpha-2 agonists such as Clonidine and guanfacine, become really, really useful. Again, I've covered this in more detail in the video here. These agents do not increase dopaminergic or noradrenergic neurotransmission. What they do is they can reduce arousal and therefore can support prefrontal regulation, emotional control, impulse control, and sleep. There are subtle differences between the two. Guanfacine is a more selective postsynaptic alpha-2A effect, and therefore they can be helpful to reduce anxiety, impulsivity, emotional reactivity, and provide a certain benefit for cognition. Whilst Clonidine is an alpha-2 presynaptic agonist, in simple terms, what it does is it steps on the brake, thereby reducing noradrenergic neurotransmission, which can be really helpful when there are sleep onset issues and sleep maintenance issues because of vivid dreams and nightmares. Because Clonidine improves non-REM sleep and can reduce or even treat restless REM sleep. Clonidine is also indicated if there is hyperarousal as part of PTSD or trauma-related aspects, in tics or evening rebound symptoms that occur post-stimulant. Clonidine can work really well here. So the key point I want to convey is this: treating ADHD is not about increasing activation. Sometimes it's about reducing the interference, the noise that prevents the prefrontal cortex from functioning properly. A regulated brain can often think better, inhibit better, wait better, choose better, and recover better. As always, when I discuss medication, it's important to recognize this is an educational video only. So none of what I cover here should be construed as medical advice. In clinical practice, I often use a synergy of a stimulant and non-stimulant, which provides optimal regulation. For others, a single medication may be sufficient. The art is matching the treatment to the person's pattern. Since we're talking about treatment, let's think about how we translate this into a clinical model. I think of ADHD treatment in phases. Ultimately, it's a lifespan condition, and therefore we need to optimize treatment across the lifespan. There'll be different phases, different environmental demands. So it's not just simply about medication, it's medication plus other psychosocial diet, lifestyle strategies. So let's look at a practical sequence. First, clarify the pattern. Before changing medication or introducing medication, understand the profile. ADHD is a condition that affects multiple domains. cognition, activity, emotional hedonics, specifically reward sensitivity, behavioral activation, behavioral inhibition, fight and flight responses, and sleep. So ask the question, what are the main domains affected? Sleep, hyperarousal, rebound, anxiety, executive dysfunction, etc. The word ADHD is not enough. Two people can have the same diagnosis but need different treatment strategies. So as part of the pattern, it's important to consider other comorbidities because they will form an important part of noise. The second part of the sequence, stabilize the foundations. Basic aspects, sleep, nutrition, routine, movement, environmental structure, and reducing as much as possible unnecessary noise, arousal. We're not looking at one or the other, lifestyle advice versus medication. It's looking at medication plus lifestyle. Simply because if the context of the environment is chaotic, the medication's going to have to fight harder. And the issue is when we think about fighting harder, it does not simply mean increasing the dose because stress increases arousal. If we increase the dose, we increase arousal and worsen cognition. So we've got to focus on reducing arousal and managing the environment. Third step, think about the targets that you're looking to address with the stimulant. Remember, the goal is not to feel driven. The goal is to improve and regulate attention, task completion, impulse control, and daily functioning without destabilizing sleep, appetite, emotional tone, or relationships. I often say treatment is about the whole day and sleep included. It's really a 24-hour cycle. And that means that dose, timing, formulation, and duration matter. In many cases, a lower dose works better than a high dose. A long-acting medication is preferable than a short-acting medication. Short-acting medications can sometimes be used as short-term augmentation agents. And an important part to consider is that dose adjustments may be needed over time. Other comorbidities may occur and need to be treated over time. The lens is never just ADHD. The fourth step in the sequence, consider regulation-based medication when indicated. If the person has prominent hyperarousal, emotional reactivity, impulsivity, sleep problems, tics, evening rebound, or even aggression, non-stimulants such as alpha-2 agonists may be worth considering clinically. And this step may come even earlier than the stimulant in some patients. In my practice, I often consider sleep first as a fundamental foundation of psychiatric treatment. Now, both Clonidine and guanfacine require specific monitoring: blood pressure, sedation, dizziness, fatigue, timing. All of these aspects need to be monitored closely. So based on what I've said, you might recognize that 1 or 2 appointments is really not sufficient to stabilize medication. ADHD is a lifespan condition and requires a lifespan approach. If you're a clinician watching this video, I'd encourage you to look at the Academy course, the comprehensive ADHD curriculum. This course bridges the gap between academia and real-life practice. The foundation of diagnosis here is a 9-step plan. Applying this 9-step strategy ensures that your diagnostic process and treatment is individualized to your patient. So if there's one thing to remember from this video, it's this: ADHD is not simply a low dopamine state. Dopamine and noradrenaline matter, but the goal is not to push them higher without limit. The goal is regulation. Stimulants can be highly effective, but they work best when sleep, arousal, emotion, and daily rhythm are considered. If the system is already overloaded, more stimulation will simply create more noise without better control. Non-stimulants such as Clonidine and guanfacine can be useful in selected patients because they target arousal, impulse control, emotional reactivity, and sleep, not through pushing dopamine, but through other mechanisms that provide regulatory benefits. And don't forget sleep. It's one of the most important treatment targets in ADHD. So if this video gave you a more nuanced way to think about ADHD treatment, hit the like button and subscribe to our channel. If you'd like deeper engagement with me, have your questions answered as a priority, consider supporting the channel through our membership option. For clinicians, you can explore the Academy by PsychScene, where you can find over 150 hours of educational material. It's a kind of psychiatry that rarely fits neatly into textbook chapters. I'm Dr. Sanil Rege, and you're watching the Dr. Rege channel. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.